Hey all, good evening to each and everyone over here. I'm thrilled to welcome you all for today's informative webinar on transfusion of blood and blood products, an overview, necessity, outcome, and adverse effect events. I'm Gagana Bellari, manager at Mediversal Academy, and I have the privilege of introducing our esteemed speaker for today, Dr. Alan Thomas. Dr. Alan Thomas, an MBBS graduate from CMC Fellow, furthered his education with a master's in general surgery at CMC, Ludhiana. He initiated his career in the resource limited regions of Uttarakhand and Uttar Pradesh, showcasing a strong commitment to excellence. Driven by his dedication, he earned a PG diploma in family medicine from CMC Vellore. Specializing further, Dr. Alan Thomas completed a PG fellowship in vascular surgery, earning FMAS fellowship recognition from AMASI. As a proud member of ASI, AMASI, and CMAI, he is also recognized for his prowess as a presenter, having been awarded Best Speaker at Guest 2022, Ludhiana. Thank you. Over to you, Dr. Alan G.
Thank you.
Thank
Thank
you.
you,
My
Gagnaji. I
pleasure.
hope I'm audible. Can I start?
Yes, sir. You're loud and clear. Over to you. Bye. Thank you.
Great. Thank you. Thank you. So this topic was supposed to be taken by a medicine person, and apparently there was some medical emergency because of which he could not present. Hematologist, I believe. So I will try my best to do justice to the topic, and the rest, yes, we can always have a discussion in the end. And this is an overview of transfusion of blood and blood products. This is a necessity, outcome, and adverse events. All right. So we're just starting off with the very basics. So about, as per some studies, 119 million units are transfused worldwide, and about 5 million Americans are requiring blood transfusions annually. Now, blood, earlier, it was stored as a whole blood unit, but now it is now divided into different components, which we will, see in the subsequent slides. Now, when whole blood is there, that one unit of whole blood, it's used only for one person. But when it comes to components, with one unit of blood, it can be separated into three components that can be used for either the same person or three different people, or whoever needs one particular component can be given only that component. So now, keeping it very, very simple, you have whole blood, which is divided into fresh frozen plasma, packed red blood cells, that's your packed RBCs, and your platelets. Your FFPs can be further divided, cryoprecipitate, cryodeficient plasma, or even fibrinogen concentrate. Because some of them, they have these bleeding diastasis, and there, you can give cryoprecipitate, or in hemophilia cases, fibrinogen concentrate cryoprecipitate can be given. Now, if you look at component separation, how do they do it? The key word is differential centrifugation. When you're writing your exam or you're giving, the key word that they look for is differential centrifugation. So here you have red cells, your plasma, platelets, and even the cryoprecipitate. So the top, as we can understand with density, red blood cells are heavy. Then you have a buffy coat, just like WBCs and platelets are there, and you have the final, the plasma. So now, how do they do it for platelets? Either you can apheresis, where, see, what do you mean by apheresis is the whole in a person, when the person goes to donate, only the component that is required. For example, with a platelet apheresis, platelets are removed and rest of the components are retransfused through the system into the body. Okay, so that is your apheresis. Either you can have single donor platelets, single donor plasma, or therapeutic plasmapheresis. Now, pre-transfusion testing. So before, no, not everybody can donate. There are some criteria who can donate, who cannot donate. Usually fit individuals are taken. For example, if more than 60 years of age, it is they avoid taking blood from them, and you always look for any chronic diseases, infections like HIV, HB. So these are pre-transfusion testing. HIV, hepatitis B, HCV, syphilis, malaria, blood grouping, very important, antibody screening, cross-matching, leukoreduction, irradiation. The RBCs are washed, especially to give it to those patients who are immunocompromised, and you don't want the reactions, transfusion reactions to happen in them. So what they do is they irradiate the blood at NAT testing, that is your COVID. Pre-transfusion preparation. Now, before transfusion, there are some preparation that is. So what happens is leukocyte, that's your WBC's depleted red blood cells concentrate. It should be prepared by method known to reduce the leukocytes in the final component. So it passes through some special filter. And when it's even transfused into the body, that also goes through a special filter. So it is called leukocyte trapping. So less than 5 into 10 raised power 8 when intended to prevent febrile reactions, and to less than 5 into 10 raised power 6 when it's required to prevent any alloimmunization or CMV infection. What happens is irradiated PRBs is 100% leukoreduced and used to prevent your graft versus host disease. So we have looked at pre-transfusion testing, pre-transfusion preparation. Not all of them undergo this. These are mainly for patients who are immunocompromised. Now, what are the equipments required for transfusion? Your blood products are transfused through intravenous tubings with filters, and their pore diameters are 170 to 260 microns. Any particular debris from being administered. However, as per American Association, you have to transfuse the blood within 4 hours. What happens is more than 4 hours, there is, as we know, blood is a good culture media. So there is a possibility of bacteria growth in or around the filter when it's more than 4 hours. Ideally, each unit should be transfused with separate blood transfusion set. But what happens in many centers across India, what happens is when they start transfusing in a busy center and all, they keep using the same. If someone has to get 2 transfusions back to back, they try to use the same set. But that should be avoided because of the thing that first blood will go for around 4 hours, and the same thing is used for the next blood. That is not recommended, and you can have bacterial growth and patient can go into even sepsis. A very, very important concept is warming of blood. They said they should not transfuse cold blood into the patient. So what they do is they try to put it in the bed sheet, under the bed sheet, try to put it in the blanket. And unfortunately, I have even heard of an instance where they try to microwave the blood. That is, it sounded very funny in the beginning, but just to warm the blood, that is not recommended. That should not be done. So what happens, there's no evidence that warming of blood is really beneficial to the patient. At infusion rates, yes. If you have to fast infuse the blood, for example, in trauma cases, somebody's a hemorrhagic patient, you need cold blood may be a contributing factor in cardiac arrest. How can you remember this? If you have heard about this cardiac coronary artery bypass surgeries, the CABG surgeries, when they used to use it on the pump means the blood is taken, particular catheters are put into the open heart surgery. Particular catheters are put in different vessels, and then through one, the blood goes into this machine where it cools the blood, and then it comes back into the system, and finally the heart is stopped. The doctor operates on the heart, makes the bypass things, and then restarts the heart. So that can even cause cold blood may be a contributing factor in cardiac arrest. So in trauma patients, make sure you don't, at least room temperature blood should be used. So warm blood is most commonly required in large volume rapid transfusion. Children infusion greater than 15 mg per kg per hour. Exchange transfusion in infants, because infants are already prone to hypothermia. So in those, and there are particular approved blood warming sets that are available. It has to be transfused through that. Patients with clinically significant cold agglutinins, and it is important to know that blood should be only warmed in a blood warmer, should never be warmed in a bowl of hot water, which many centers do, as this could lead to hemolysis and which could be life-threatening. The RBCs can break down, cause increased potassium to be there in the blood, and that can be a reason for your cardiac arrest. So do not warm the blood other than certified blood warmers. Time limits for infusion. You have whole blood cells within 30 minutes of removing the pack from the refrigerator. you have to start the infusion, complete the infusion within 4 hours. Platelet concentrate should be given immediately and within complete the infusion within 20 minutes. FFPs within 30 minutes start the infusion after thawing of the blood of the FFPs, because FFPs are literally frozen. Okay. And they thaw it and give it. So as soon as it's thawed, you have to, within 30 minutes, you have to start and finish the infusion within 20 minutes. This is ABO typing. I would spend a couple of minutes on the slides. Very, very important. As we can see, there is antigen A, antigen B, antibody A, and antibody B. Just follow the red pointer. So what happens is, if you have a blood group type A, okay, you have antigen positive. Yes, A antigen that is present. No antibody. You should always understand antibody fights your antigen. So if you have an A, you cannot have an antibody A, otherwise A and A will cancel. Okay, but you can have an antibody B. Now I'm coming to the significance of that. Same thing, if you look at B, it will not have an antigen A, it will have an antigen B, it will have an antibody of A. Of course, it will not have an antibody of B. So B will not cancel B. So that's right. O, there's no antigen, but there are both antibodies, anti-A and anti-B. What happens in AB? You have antigen A, antigen B, antibody. There are no antibodies. So if you look at AB becomes the universal recipient. If you look at, it can receive blood from any of the groups, AB. Okay, if ideally AB AB, it should receive AB type blood. If there's a deficiency, it's a universal recipient. It can either get from A, B, or O. However, if you look at O can be, if it's an O group, so if patient is of O group, you will have to give O group blood. You cannot give A, B, or AB. Why? Because in O group, you have antibody A, which will fight your A, antibody B, which will fight your B group. So your A and B group cannot be given in O. So O becomes a universal donor. O can give to anyone. Okay. And AB becomes your universal recipient. Whole blood and PRBC. It's a summary of the slide I just explained. ABO and RH compatible are cross-matched. In the absence of ABO type specific blood, group O can be transfused because, as I told you, it becomes a universal donor. RHD, negative recipient, should receive the blood. However, RHD negative whole blood or should receive RHD negative patients should get only negative RF negative or red blood cell components. However, if you look at the RHD, that's a rhesus D factor positive, can receive either from positive or negative or red cell components. Your negative fellow cannot get a positive blood. That will cause a reaction. That's why I say AB negative can get AB negative, or you cannot transfuse AB positive to a AB negative patient. But if it's AB positive, patient can be given either AB positive itself or AB negative. That will not be a problem. If we look at compatibility testing, single donor plasma, fresh frozen plasma should be ABO compatible. RH compatibility is not compulsory in your FFP. Cryoprecipitate also does not require AB or RH grouping. Let's go back again. Sorry. Single donor plasma should be only ABO compatible. RH compatibility, that is your positive and negative, is not really compulsory in your FFP. If you look at a cryoprecipitate, they don't require either ABO grouping or RH. Anybody can be given anything. Platelet concentration should be ABO and RHD type specific with the recipient blood as far as possible to reduce the number of reactions. In case there's a shortage of RDPs of any group, of any AB or RH group should be used provided there is no visual red cell contamination of the platelet concentration. Because once your RBC comes in, that itself can cause an ABO reaction, incompatibility reaction. Okay, in case of single donor platelets prepared by apheresis, plasma should be reduced when the plasma incompatible concentration is in use. Example, the use of O group SDP to the B patient. Now, if you look at whole blood should be stored at 4 degrees, plus minus 2 degrees up and down, in plastic bag. Now, how long can you keep the blood? So there are four, solutions that are made, and the blood is kept in that. Especially it comes pre-prepared bags. So you have citrate phosphate dextrose solution. If the blood is stored in those particular bags, it's called the CPD bags. That's 21 days. Then you have citrate phosphate dextrose with adenine. That increases for few more days to 35 days. Heparin solution bags should be used within 24 hours. Red cells containing any additive solution like SAGM, Adsol, Nutricell. So that can be kept up to 42 days. Now, what happens when the blood is stored? I don't know if you've heard of this 2,3 BG component that's formed. So what happens is there is decrease in the blood oxygen carrying capacity. Older the blood, decrease in the oxygen carrying capacity. Bisphosphonate group 2,3 BPG. Now, if we look at whole blood, what are the indications of a massive hemorrhage, neonatal exchange transfusion, preferably within 72 hours of collection, but not exceeding 5 days, should be used for exchange transfusion. Now, if you look at the whole blood, does not contain any viable platelets or labile coagulation factors. Packed RBC. So, if you look at transfusion requirements in critical care guidelines, if your value is less than 7 grams, that's the threshold for critically ill patients. The guidelines recommend a value of 8 grams if it's with a coronary artery disease patients. Transfusion may also be indicated in patients with active or acute bleeding and patients with symptoms related to anemia. For example, tachycardia, weakness, dyspnea, and a hemoglobin if it's less than 8 grams. So the ASA task force recommended a perioperative transfusion trigger of about 6 to 10. We say, okay, if it's a elective surgery, at least 10 grams of blood should be there based on potential or ongoing bleeding, intravascular volume status, signs of organ ischemia, and adequacy of cardiopulmonary reserve. Not everyone needs to be transfused less than 8, but less than 7, it's a threshold for critically ill patients. Of course, you have to understand whether the patient can take that much of blood, because this is 4 hours, the blood has to be transfused. So, for example, in renal patients, what they do is the transfusion of blood usually happens during the time of dialysis, so that extra circulatory overload can be removed from the system via the dialyzer. If you look at the PRBCs, packed red blood cells, 1 unit of PRBC increases the hematocrit by about 3%. And HB by 1 gram. Unless the patient is actively bleeding, it is recommended that you transfuse 1 unit packed cells at a time, followed by checking post-transfusion hemoglobin at least after 6 hours. No point immediately transfusion is over and you check after 5 minutes. You have a very wrong reading. Storage changes, as I mentioned, 2,3 DPG, your dysphosphoglycerate, depletion, inflammation, pro-inflammation, poor deformity, and change in the nitric oxide physiology may alter the effectiveness of transfusion. What happens is, if you look at the normal blood circulation when it comes to the lung, the blood has, RBCs have oxygen carrying capacity. So once rich oxygen is there in the lung, once it goes into the peripheral tissues through the blood vessels going to the liver, the kidney, other areas, the tissues, stomach, intestines. So this carried oxygen, they dissociate at the tissue level and improve the oxygenation at the tissue level. So oxygen is collected from the lung, okay, and then it is given off at the tissue level. So if there is storage changes like 2,3 DPG, what happens is at tissue level, they will not release the blood. They will just keep holding on to the oxygen. Okay, because of this 2,3 DPG depletion, they will not release the blood, oxygen in the blood. So what happens? There is tissue hypoxia. So that can be there if you use a old blood. Not whole blood, old blood. Platelet concentrate, random donor platelets or single donor platelets. Of course, many of you are aware during the dengue season, they transfuse RDPs or STPs as required. So it's prepared by the centrifugation of single unit of whole blood collected, while SDP is collected by the apheresis method. As I told you, apheresis, you take the component of interest, you separate that, and remaining your RBCs, plasma, or your WBCs, you push back into the patient. So apheresis, there is a particular machine that does this. Platelet concentrate should be separated from the whole blood within 8 hours of collection by centrifugation at 22 degrees using platelet-rich plasma (PRP) or a Buffy coat method. Platelets is suspended in approximately about 50 ml of plasma and stored at 22 plus minus 2 degrees Celsius. So the minimum amount of plasma that you can keep while transfusing to the patient, that will reduce your number of reactions, platelet-related blood reactions. Why? Because your plasma has some component of WBCs, and that can your leukocytes that can cause your reaction. Now, when do I transfuse? Very important. Not everybody less than 1 lakh you have to transfuse. So to prevent any spontaneous bleeding, transfuse at less than 10,000. Some of the recommendations say even 20,000. But 10,000, some recommend even 5,000 cells a microliter. But that is almost, by the time it reaches 10,000, you have to, transfuse. However, generally accepted count is 50,000 is sufficient for most invasive procedures, including most surgeries. However, if it's a really elective surgery, I think unless patients have any major problem, you can always wait for the counts to reach 1 lakh for any surgery. And recommended mainly for ophthalmic and neurosurgery. Now, platelet transfusion, you should understand, threshold in bleeding patients. So less than 50,000 and there is evidence of bleeding like hematuria, DIC, you can transfuse. Less than 30,000, when bleeding but not considered not severe, still you can transfuse. And less than 1 lakh for bleeding in multiple trauma patients, don't wait for it to go down to 50,000. Bleed multiple trauma patients with intracranial bleeding, of course, you may have to consider transfusion of platelets. Now, if you look at platelet concentrate, your group specific transfusion is recommended. Okay, however, the indication is thrombocytopenia and massive transfusion protocols. Your TTP and your heparin induced thrombocytopenia considered relative contraindication to platelet transfusion. Why? Because if you give them platelets will be consumed and your platelets are wasted. You should understand blood and blood products are very, very precious. You cannot buy it with money. You will have to give blood, then only the components can be made. It cannot be made out of thin air. So 10 ml per kg of random platelet increase the platelets count by approximately 5,000. But what happens in SDP increase the platelet count by 25,000 to 30,000. So if you want a sudden hike in platelets, patient has to undergo some emergency surgery, it's always better to give off single donor platelets. Those are around 10 to 50 ml per kg. Shelf life is 5 days. Filter 170 to 260 is used for translation, stored at room temperature. Bacterial contamination high due to room temperature storage, and they are WBC depleted. Now, if you look at FFPs, one unit is around 250 ml to 30 ml. One apheresis unit will be around 400, 600 ml. If you look at FFP transfusion to PRBCs, PRBCs to FFPs, initially the ratio is 3:1, but then now they say you have to give 1:1:1. That is platelet, red blood cells, FFPs, and one platelet, bag of platelets. So if it raises the fibrinogen level by 10 to 15 ml per milligram per deciliter, and tissue pathway, that is your external pathway of clotting that contains fibrinogen 400 to 900 milligram per unit. So FFPs will contain that. Factor 7 has the shortest half-life. So FFP should be separated from the whole blood, not later than 6 to 8 hours of collection. Very, very important. And frozen to -30 as early as possible. So it once thought it should be used within 6 hours. Ideally, once thawed, it should be used immediately, but they say some recommend say up to within 6 hours, it has to be consumed. Cryo-poor plasma, factor 7 deficient plasma, is a plasma from which cryoprecipitate has been removed. FFP can be kept for about 1 year at -30 or below up to 5 years at -60, because -60 is a very difficult temperature to attain. -30 is still possible. Um, so that can use shelf life of about 1 year. After 1 year, it is labeled as unused plasma. Coagulopathy, inherited or acquired plasmapheresis, antithrombin 3 deficiency, pseudocholinesterase deficiency, urgent reversal of warfarin, you can give FFPs, should not be used as a plasma expander or protein substitute or wound healing. Some centers do use it, and that is a very, very wrong practice and should not be used. Now, what happens in cryoprecipitate? Prepared from the cryoglobulin fraction obtained by thawing the FFPs. So after the removal of the supernatant, the precipitate that is there is refrozen in approximately 30 ml of plasma, which can be again stored at -25 for about 36 months. And contains factor 7C, 8C, von Willebrand factor, fibrinogen, fibronectin factor 13. This is usually packed in the 15 ml of plasma. So each cryoprecipitate will have about 150 of mg of fibrinogen, and 1 unit of FFP will contain about 2 to 4 milligram per milliliter of fibrinogen. It's equivalent to fibrinogen content of 2 units of cryoprecipitate. So FFPs can be given, but sometimes they do cryo is kept separately for patients requiring cryoprecipitate, especially in hematological centers. So 10 units of cryoprecipitate should restore your fibrinogen level to 200. Cryoprecipitate administration is being replaced by the use of lyophilized human fibrinogen concentrates. These are the new recent advances. So as mentioned, normal plasma concentration of fibrinogen is 200 to 400. Fibrinogen is the major structural component of the clot, and fibrinogen becomes your fibrillator. Minimum level required to maintain hemostasis is at least 100 milligram per deciliter. And you have concentrates that are superior to FFP or cryoprecipitate in the management of fibrinogen deficiency. Of course, as you know, it is expensive. Coming to the most ending part of the slides, you have something known as massive blood transfusion that you can see. So what is the definition? The replacement of greater than 1 blood volume in about 24 hours. 50% of the blood volume, more than 50% in about 4 hours. So if it's actively bleeding and they're continuously transfusing patient, something like a femur fracture or amputation of the limbs. 10 units or greater than PRBC has been transfused, then you have to activate the massive transfusion protocol. Greater than 150 ml per minute. If there is a loss of blood, then definitely you will have to activate the MTP, the massive transfusion protocol. Children, more than 40 ml per kg transfusion is required. Blood volume children 1 month is approximately 80 ml per kg. Now, what is a massive blood transfusion? If you look at massive blood transfusion, you have when the amount of blood approaching or exceeding recipient's total blood volume is transfused within 24 hours. A fresh blood sample should be used for cross-match at the time of subsequent transfusion of blood. And component therapy should be actively considered in these cases. In case of need of transfusion after 48 hours, the fresh sample should be asked for to perform a cross-match. Very, very important. Now, if you look at massive transfusion protocol template, so who decides the MTP activation is a senior clinician. Okay. Baseline, you have to send all the blood coagulation, fibrinogen levels, biochemistry, ABG. You have to notify the laboratory, the transfusion laboratory, to activate the MTP. So the lab staff will quickly prepare and issue blood components as requested, anticipate repeat testing, blood component requirements. Keep following the red dot, minimize the test turnaround time, consider the staff resource. This is like an emergency for them. You have to quickly do the cross match and then give the blood. They have to work in liaison with the laboratory and the clinical team, assist in interpretation results, advise on blood component support. Sometimes components may not be available, so that has to be arranged. Now, senior clinician can request 4 units of RBC at a time or 2 units of FP. What happens is sometimes in the sense of panic, we will order more FFPs and RBCs, and that cannot be returned to the blood bank. And that has to be used. And sometimes the blood gets wasted. Blood is a very, very precious resource. So you have to use it very importantly. Consider 1 adult therapeutic dose platelets, tranexamic acid in trauma patients. And also include a cryoprecipitate if fibrinogen is less than 1 gram per liter. By the time, don't wait for the report. initially start off with PRVCs and FFPs and later 1:1:1 if you're actuating the MTP protocol. Bleeding is controlled. Yes, notify the transfusion worldwide to seize the MTP program. That's a massive transfusion protocol program. No, then you have to again consider the transfusion and tranexamic acid. Optimize, obviously, you will have to localize the cause of bleeding, so splenic rupture or limb amputation. You have to control the source of bleeding. Every 30 to 60 minutes, full blood counts, coagulation screen, at least 60 minutes, aim for a temperature. Hypothermia is a very bad, killer of the patient. Patient can go into DIC, disseminated into vascular coagulopathy. pH of greater than 7.2, base excess -6, lactate of less than 4. Platelets at least keep above 50,000. Less than PT-INR, less than 1.5, INR less than 1.5. Fibrinogen more than 1 gram per liter. So if you see, we have talked about 200 to 400. Okay, here we talk about 1 gram per liter. Now, if you look at the values to aim for, this is already discussed. The same thing should not be used alone as a transfusion trigger and should be interpreted in context with hemodynamic status, organ, and tissue transfusion. So it's not with only hemoglobin levels you will start transfusion. You have to correlate with the patient. Now, looking at the important parts of the slide, complications of blood transfusion, very, very important. Before we come to the complications of blood transfusion, you should always understand the transfusion of blood needs to have consent that taken. Some of them may agree for transfusion, some patients may not agree for blood transfusion. So whenever we take a consent, you have to tell them that this is the benefit, this is the risk of transfusion, and the informed consent should be taken from the patient or the next of kin. Sometimes the patient is in trauma bay, and you cannot take facial injuries. You can't take consent. You have to ask the next of kin that transfusion needs to be done. So you kindly give consent. But in emergency, you can transfuse. It's a very gray area. Some of them may not agree to the transfusion also. There are some particular religious group that do not allow transfusion of blood of another victim into their own bodies. So they're called Jehovah's Witnesses. They're a group of religious group. They usually don't allow blood transfusion into them. So what if they now you might ask what do they do if they have to undergo any surgery? So if it's an elective surgery, what they do is maybe a month before or something, they go and donate their own blood and keep it in the blood bank and make sure that blood itself is getting transfused into them. So as I talked about, consent is very, very important. And the person who is carrying the blood has to cross-check from the blood bank that whether because he may not be the only person at the blood bank. You can always exchange the blood bags by mistake. So always before leaving the blood bank counter, you have to ensure you're taking for the correct patient, the correct hospital ID number, and of course, very, very important, the group that has been mentioned at the request form and the blood. And blood will have a tag. Blood bags will always have another tag to it, which will mention all the details of the blood, the volume, the group, the RH typing, everything would be there. So that is very important to cross-check that prior to your collection from the blood center. Now, what are the adverse events or approximate risk per unit of transfusion average? Febrile reaction is 1:60. Transfusion reaction associated with circulatory overload, as I mentioned, maybe renal patients or cardiac patients, 1:100. Allergic reactions, 1:250. TRALI, transfusion-related acute lung injury, 1 in 12,000, quite rare. Hepatitis C, 1 in 11 lakh 49,000. HIV, 1:14 lakh 67,000. And fatal hemolysis, 1 lakh 19,000, 11 lakh 97. 1:19 lakh and 72,000. So now, if you look at the adverse reactions, so less than 24 hours, you have acute immune-mediated transfusion. You have hemolytic transfusion reaction, febrile urticaria, anaphylaxis. TRALI can be a possibility. If you look at The other acute non-immune mediated transfusion-related sepsis, non-immune hemolysis, transfusion-related circulatory overload, air embolism. These are non-immune. The first one was the immune mediated, something you have delayed. You have acute and you have delayed. Similarly, you have delayed immune mediated more than 24 hours after transfusion. You have delayed reactions. You can even have your transfusion-associated graft versus host disease post-transfusion purpura. Delayed non-immune can have iron overload, transfusion related sepsis. There's something known as window period. So what happens in case the patient is having HIV and he's in the window period, his HIV test may be negative. However, when that particular blood is transfused into a patient, there is a possibility that he may develop HIV in the coming years. Now, febrile non-hemolytic transfusion, you have relatively common complications with the frequency of about 4 to 30%. Antibodies, important factors I will read. Antibodies against the HLA or leukocyte antigen donor plasma are most commonly implicated. Your febrile non-hemolytic transfusion reaction can occur due to biological response modifiers released during platelet storage, which is increased with the storage. So that's why platelets are kept more than, then they can have your febrile non-hemolytic transfusion reactions. Febrile non-hemolytic transfusion reactions continued. You can let additive solution pass, which replaces maximum plasma in the stored platelets. Now, circulatory overload, if you look at, it's characterized by respiratory distress secondary to any cardiogenic pulmonary edema. And fluid overload state is there. Diagnosis based on the symptom onset, 6 to 12 hours, important. Clinical evidence of fluid overload, you might have pulmonary edema-like features, and your elevated BNP may be there, and response to diuretics. Patient might improve with one shot of diuretics. Now, what are the preventive efforts? Of course, you have to slow transfusion rate. However, you cannot really slow it down because of problem of clotting of the blood, and you can even have bacterial overgrowth. And you can either administer diuretics in between your transfusion, 10 or 20 mg of Lasix. Allergic or anaphylaxis, similar to FNHTR, and its frequency is 0.09 to even 21%. How does it manifest? It manifests as pruritus, urticaria, or systematically bronchoconstriction, may have breathing difficulty, and seldom associated with fever. And can occur when the patient is IgA deficient and has antibodies against it. Usually they don't check for IgA. So when they wash out use the washing method, platelets, that can prevent this kind of anaphylaxis. And allergic reactions can be minimized by depleting the plasma and platelets, as I previously mentioned. Your graft versus host disease is quite rare, but fatal complications are characterized by fever and multiple systemic manifestations, skin and GI tract, liver, and others. And of course, transfusion of viable lymphocytes that get a favorable environment for the recipient, and they proliferate, attacking the host tissues. Occur to 1 to 6 weeks from transfusion, and multiple organs are involved. Suppression of bone marrow may be there, and diagnosis that of exclusion, and you should not put that as the first shot. And this can be prevented by the irradiation of platelets. Trali can occur about 1 to 12,000 people transfusions, mainly caused by the transfusion of antibodies in the plasma from the donor against HLA or human neutrophil antigens. 2 to 4 hours is the time period, and develops acute hypoxemic ARDS-like symptoms, pulmonary edema. Patient may have normal CVP without left heart failure. All right, heart failure may not be there. Yeah. Diagnosis is usually made with the history of any recent transfusion. So if in the history, the patient might have undergone recent transfusion, chest X-ray with patchy infiltrates. Apart, once you diagnose, you take out all other diagnoses, then you can put Trali as the diagnosis. 10% the mortality is there, and supportive care, 96 hours, 90% of them improve. Sepsis and bacterial infection, very commonly, you can understand that if there's a blood infection and you're transfusing infected blood, then definitely patient can, develop the infection. Not just that, Apart from improper cleansing of the donor phlebotomy side of the donor has asymptomatic bacteremia. Pathogen reduction technology has been used to minimize infection, plasma, and platelets. Now, if you look at fatal hemolysis, extremely rare, 1 2 million transfusions almost. Develops acute onset of fever and chills, low back pain, flushing, dyspnea, and as well as tachycardia, and going into state of shock. Immediately, any of these reactions, you have to stop the transfusion. Leave the IV line in place, intravenous fluids with normal saline, keep the urine output greater than 100 ml per hour. Diuretics may also be needed. Cardiorespiratory support may be provided if required. So hemolytic workup is sending the donor blood tubing post transfusion and retype cross match, direct, indirect Coombs test, and complete blood transfusion, PT creatinine drawn from the other arm, peripheral smear, and certain haptoglobin, indirect bilirubin, LDH plasma free. And urine analysis also, we need to see if there is any hemolysis there, if HB is there, hemoglobin is there, presence of any hemoglobin in the urine. So just two important things, hyperkalemia and hypocalcemia. Hypocalcemia can result as citrate or anticoagulant in the blood products binds with the calcium of the blood. Hypokalemia can also result in alkalization of blood as citrate is converted to bicarbonate by the liver in patients with normal hepatic function. So that may not be. Now, if you look at summary of the symptoms of when somebody is being transfused blood and patient has itching, what do I look at? If it's patient transfusion-related allergic reaction, or is it really a graft versus host disease? That is usually a little later. So you stop the transfusion immediately. That is very, very important. Send report to the blood. Don't hide the thing, but report it. See, sometimes patients may have received the long blood bag. So two patients are lying side by side wanting to receive transfusion. The blood bags can get exchanged. So always cross-check the blood before transfusion. Fever, septic transfusion, Trali, febrile, non-hemolytic transfusion reactions. If it's dyspnea, you get severe allergic reactions. Trali may be a possibly air embolism. Hypotension, definitely look at more serious than Trali, transfusion-related sepsis, air embolism, acute hypertensive transfusion reaction. Thank you. So yeah, great. So our presentation is over for now, and the floor is now open for questions. If you could quickly put it in the chat box so that we can start answering them. I hope I'm audible to you all. Okay, Daniel, I will do that. Repeat about cryoprecipitate and indication for cryotransfusion. All right, I will do that right away. Just trying to share my screen. 1 second. So as you can see, FFP is further on to cryo and cryodeficient plasma 50 concentrate. Now, if you look at fresh frozen plasma cryoprecipitate. So it's prepared from the cryoglobulin fraction obtained by thawing your FFP. All right. And after removal of the supernatant that is on top, the precipitate is refrozen to approximately 30 ml of plasma, which can be stored. I'll just use the pointer. which can be stored at -25 or below up to 36 months. Now, it contains factor HC, von Willebrand factor. Again, we use these mainly in hematological patients, okay, and factor 7 deficient, factor 8 deficient patients, and fibronectin factor 13. Usually, it's packed in 15 ml of plasma. It comes in short sponge, and each unit of cryoprecipitate contains about 150 to 250 mg of fibrinogen, and which is equivalent to the fibrinogen content of about 2 units of cryoprecipitate. Now, 10 units of cryoprecipitate should restore the fibrinogen level to about 200 milligram per deciliter. Cryoprecipitate administration is being replaced by the now use of lyophilized salt. Fibrinogen concentrates are superior to FFP or cryoprecipitate in the management of fibrinogen deficiency. And not all centers, they have the facility to really, make cryoprecipitate. So it's a little difficult to maintain your cryoprecipitates. Better that. I hope this is I was able to answer.
Alan Ji, we have a question from um, Dr. Professor Shilpa J. Respected sir, when a woman is on a period and her hemoglobin is found to be 13, can she transfuse the blood, sir?
See, ideally, for women, the criteria is quite strict for transfusion. Not easily, I mean, women can give blood, but this part, when a woman is on a periods and hemoglobin is found to be 13, it's a very difficult question to answer. It depends. I need to recheck on that whether you can transfuse or not. But ideally, they would refuse. Especially in centers where are not very common. Maybe in the places where not easily healthcare accessibility is not there, but there is somehow a blood bank is there. They would say, okay, finish your periods, recheck the blood, and then transfuse the blood. So for women, the criteria is quite strict, and of course, you have to give a proper menstrual history, and you have to maintain the blood. And between two transfusions, sorry, between twice donor, you will have to wait for a period of 3 months, either man or female. No, what I understand from Professor Shilpa is, can she donate the blood? Is what I understand. Dr. Daniel, I feel what she mentioned is, can she donate blood? Is that right, Professor Shilpa? Yeah. So I believe,
Yes, sir.
yeah, great. Yeah.
Thank you, sir.
Komalpreet has a, thank you. Komalpreet has a question. Will the coronary grafts be rejected if incompatible blood is transfused? Well, if you're using, see, coronary grafts can have two types. Either you can use your veins, your long great saphenous vein, that is mostly used, or your veins of the hand, of your forearm. So what happens is, if there is incompatible blood, there's formation of blood clots. And when the coronary grafts, there is blood clotting inside the coronary graft, of course, the graft will not function. The conduit or the free pathway is not there because there is a blockage of that. So naturally, the coronary grafts can be rejected if there's incompatible blood. So that is the thing with both. If you're using a PTFE or if you're using a external graft, material graft, that also, of course, if there is a clotting of blood in that, then definitely that can also be reduced. What is cold blood? If you, Dr. Deepak, if you look at, whenever if you've been to the blood bank, when you receive the blood, it is most of the time it is cold. It's not frozen, but it is cold. It's taken from the blood fridge, a particular fridge that is maintained at around 4 degrees, plus minus 2 degrees. So when you receive that it's called cold blood. So by the time they reach the ward, the sisters, what they do, they try to, warm it, they put it under the armpit, they do all the sorts of methods to warm the blood, which is not recommended. Just leave it to a room temperature. Within half an hour, once you release the blood, you have to transfuse the blood. I had already mentioned in my slide where, transfusion of clotted blood can even lead to cardiac arrest. Um, then what's the next question? Let me. Thank you, Dr. Venkatesh. Yeah, there's one more question. Can you repeat? Uh, second. Gagna ji, can you just check if there's any other question? Before transfusion, hydrocort is given. Protocol is now running or not. See, hydrocort at some centers, some clinicians um, do for
Ah,
the, uh, you know,
sorry, LNG. I'm really sorry
yeah,
for the inconvenience.
no,
I
no
was
problem, no
not
problem.
able. I was not able to.
No, no, I'm answering the question. I just found one question. Before transfusion, hydrocort is given or not. So what happens? Some centers to prevent, any adverse reactions or allergic. So what happens is allergy, they give off hydrocort and Neville. Okay, stop the blood transfusion. Ideally, that's a practice. But if you give pre-op hydrocort, yes, it can. It's sometimes given in those patients where they're immunocompromised and you don't want any form of transfusion reaction. So not routinely, it is not a routine in a normal routine blood transfusion, normal patient, you don't need to give hydrocort. Yes, Lasix may or may not be given, again, depending on the clinician. Sir, if the blood bank is far away from the hospital, within how many hours it to be get transferred? Is there any possibility of hemolysis? Yes, definitely. What happens is there is a possibility. See, there's something known as blood. There are blood carriers. Okay, blood carriers have a possible ice pack and maintain the temperature. So the blood is not just given in the hand; it's put in that ice box. It's closed from the center, and that can be used as a transport region and try to transfuse immediately as soon as the blood is arrived at the transfusing hospital. So Ajay Kumar, Buffy coat. Buffy coat is nothing. I'll just show in my this one. Buffy coat is that middle layer that is there. As you can see in my slide, this is your lowest will be your RBC. Okay, you in between you have the Buffy coat here, and up you have the plasma. Okay, so once you centrifuge, these three layers are formed. Yeah, so this is your Buffy coat.
Anjay, I think there are no more questions. I think there are no questions. Uh,
Sure.
yeah. Mm.
Sir, if a patient got mismatched blood transfusion, how would it be normalized from its side effect? How to normalize? So, if mismatched blood transfusion, always report to your senior. This has happened. Do not hide it. Report to the blood bank. You have to, wait for see how what all the patient is. If patient is having breathing difficulty, give him oxygen. Give him hydrocort, Avil, and you have to wait for the side effects that are there, and then based on that, you treat the to a conservative management accordingly. Sometimes if it's very bad, you patient may have to even undergo apheresis kind of picture, even dialysis to remove that blood that is mismatched.
I'll take a moment, Alanji. I have dropped a link in the chat box for you to fill out and submit to receive your certificates of participation. Please don't miss. Also, currently also I'm sharing the link. I think, Alanji, there is no questions. Very good presentation. Thank you. Nice presentation.
Yeah, do leave a
Thank you,
feedback.
Alanji. Yeah.
And also, I wanted to mention of late this month, we have also come up with a lot of courses, fellowships, and diplomas on our page. Do visit Mediversal. So, this is the website. Think, wait 1 second. Just put it on the thing. So right now, very good because this is September, month of September, and a lot of courses, new courses have been, fellowships and diplomas with and without, we have our own recognition also, the university recognition also that is there. If anybody is interested, especially for people who have attended this webinar, and whenever you have mentioned when you if can mention this as your coupon code, so you'll be offered about 10% discount in the fellowships or diplomas accordingly. And this offer is there for this month. Yeah, so you can always contact our Gagna, can you leave the this one the contact
My
number
email
also,
ID.
contact number also,
The
and
session will be end there.
yeah, this is the link. You can directly go to the website and, once they connect you, that you can always say that, of course, you'll have a certificate and all that. Yes, very well. BM, our courses are usually upskilling courses. We don't restrict anybody in joining our course. The only concern is, clinical attachment. To be very honest and fact, many of the hospitals do not, mainstream hospitals do not allow this one BAMS or BHMS to go for clinical attachment. However, we have also overcome that problem in certain states. If you're willing to travel to certain states, we can also provide you clinical attachment for BAMS candidates also. There are certain hospitals we have tied up with who are willing to take BAMS candidates into emergency medicine and, certain departments of the hospital. Maharashtra is one of the states where the government allows to take up this one, and they allow hands-on. Not, I would say, more of an observership. Hands-on would be totally upon your this one. That would be it. And advantages of doing the fellowship course, yes. The advantages are, you can always uh, good to be upskilled, or whenever you go for an interview. For example, you're going to an interview panel and you have doctors in front of you or staff in front of you, and you have about 5 other candidates. If you say, okay, I have worked in the internal medicine or a critical care medicine, and you provide a certificate to them, okay, whether it is recognized by a university or not recognized, that's a secondary issue. But when you say, and 4 others don't have that certificate, somebody who's looking for a JR or junior resident for the ICU setting or critical care, definitely will have you will have an higher edge. Um, you will have an higher edge in, getting through the interview. So you have completed online fellowship courses are considered, of course, as I told you, when you go to an interview panel, you cannot say that none of the courses by any online company are, approved by the NBE. However, there is, as per the NMC guidelines, you can put it as a suffix under your name. As per 1.4.2, you can put it as a small suffix, provided you mention where you've got the course from. So online fellowship courses are considered or not. So that completely depends on the interview panel. So we can always have an academic session, where you can put in your queries. I do a lot of academic and, uh, I do a lot of academic and career guidance. You can always have a free webinar on that. And online courses recognized by MCI, I'm not very sure, Dr. Sir. Usually, if MCI has to recognize a course, it has to be through, if it's a fellowship course, it has to be through the FNB exam that's conducted once or twice a year. So, fellowship exam conducted by the NBE, and that's only very few courses that are there that are recognized by the MCI. However, if you look at the time duration that you spend with them, may not be so beneficial, as many of you are working professionals. And our online fellowship, we provide this complete LMS program, online LMS programs, and we provide a lot of CPD approved. Many of the courses, as you can understand, are CPD approved courses. UK. So if any of you are trying abroad, so our online courses kind of really, it gives you a boost on factor if you have CPD approved credits for UK. So if UK, Canada, if you look at UK NHS, so that CPD approved courses can be really helpful. So you can, our courses are CPD approved. So when we give a certificate, we provide this one. So Abhishek has also put in a question. I've completed Bachelor of Radiology, and can I be eligible for post-graduation of emergency medicine? Of course, it depends on what you want to practice at the end of the day. So if you want to practice as a radiologist, Bachelor of Radiology means what course is that exactly? Is it a BSc course, or is it a diploma course that you've done? So if you're can I be eligible for post-graduation in emergency medicine? Yes, you are eligible, because it's an upskilling course. You can take any courses under us. And when we provide the certificate, we make sure that it is CPD approved. And also, one more thing that we do is, when we provide the certificate, we apostille it and give it. And online fellowships courses are considered. Online courses are recognized. How about USA? We are now actually coming up with something new also from Up to Date. We are trying to collaborate with them. And what happens with them is, you can generate certificates. And that American Association is also part of it, what I understand. So USA, more importantly for UK, it is already in place. You have CPD approved credits and all that. And you can, for UK, it's for USA, I need to go back and cross check. But for American Association, once we join in with Up to Date, you can always, always check with us, and yeah, that can help, because that certificate comes from the American Association, generated by Up to Date. I've already taken admission one of your PG diploma courses. Excellent. I am an MD Ayush doctor. Will it be considered an interview? And can I use it as a degree, as an add-on to my other degrees, as a suffix? PG diploma course in what, Tasmita? Can you just quickly tell me? Okay, PG diploma in infectious, mainly these are upskilling courses, as you can understand very well. And see, when you provide, first of all, I believe you will go to a hospital where they consider Ayush doctors. And in that, will it be considered in an interview is totally upon the interview panel. Okay, if you have other colleagues who have only one certificate and you have about 3 or 4 certificates, naturally, if I am in the interview panel, I will have a more liking towards the candidate who has more certificates or who is a little more overqualified, and I'm paying the same salary. Yeah. So if I get somebody with three certificates and I pay only say about X amount of money, and I have to pay the same X amount of money to a person with one degree, naturally there's a possibility how you present yourself in the interview, and you can always say that it's an upskilling course, and always don't try to hide from them that it is an approved course and all that, because you can always get caught because of that. So when you are open and say it's an upskilling course to the interview panel, definitely you can you can always mention, and that will leave a good impression on the candidate on the interview panel. So that kind of really helps. And after fellowship course, can you write allopathic medications? Dr. Israr, I'm not very sure on that part. To be very honest with you, I will not hide things. I will be very honest with you. Writing allopathic medications, you need to have a license from the your local allopathic provider. So, for example, if you're from Delhi, you need to have Delhi Medical Council. If you have from UP, UP Medical Council. So wherever, whichever state, if they give you approval or license, your license to practice allopathic medicine, then definitely you can write. But provided your local council, your state council should approve you of your degrees that you have. And of course, people will come to you based on your clinical expertise and your talent.